Hello, everyone. And we know we have a very long list of audience who will join us as this picks on. And I'm very excited to invite everyone to this new initiative of Krea Dialogue Sans Borders. With more than 20 eminent speakers from across 7 nations, the Global Dialogue Sans Borders is a 4-part panel discussion series. So this conversation brings together eminent subject experts from world-renowned institutions and research organizations, along with the academic minds at Krea, on the post-crisis future of our nations, the health, families, societies, environment, and the interconnected world we all live in. So we welcome you all to the first edition of Global Sans Borders, and the theme for today is Future of Public Health. Today's panel is a mix of experts who will share with us their perspectives, which stems from their vast experience of research and as practitioners about the public health systems of the future, COVID-19's impact on public health practice, investment, research, and interventions. Quickly introducing our panel today, Susanna Dunachie, Principal Investigator, Clinician, and Researcher in Global Health at the University of Oxford. Susie is an infectious diseases clinician, an Associate Professor in Tropical Medicine at the University of Oxford, undertaking research to understand the human immune response to COVID-19 and to neglected tropical diseases. Dr. Vivekanand, Executive Director, the George Institute for Global Health, a James Martin Fellow at the George Institute for Global Health at the University of Oxford, and the President of the International Society of Nephrology. Dr. Jha has worked with many organizations, including WHO, to develop clinical practice guidelines and advocacy papers. Professor John Matthew, Associate Professor, History of Science at Krea University. John holds 2 doctorates, one in Ecological Sciences from the Old Dominion University and the other in History of Science from Harvard University. His instructional experience includes anthropology, biology, geology, history, and the history of science. He's also actively researching the plague and influenza epidemics in India in the 1890s and 1918 to 19 respectively. Kalyan S. Chakrabarti, Assistant Professor of Biological Science and Chemistry, Krea University. Kalyan's work primarily focuses on protein dynamics, and he's the coordinator of an international collaboration to develop a comprehensive framework for investigating protein dynamics involving the Max Planck Institutes in Germany and the University of Louisville in USA. Shailendra Swaminathan, Principal Economist, Lead at Krea University. LEAD is a collaborative hub that brings experts from diverse disciplines and sectors together to develop sustainable, innovative solutions by harnessing innovation, technology, and analytics. Shailendra provides strategic and thought leadership to shape LEAD's research, design, and agenda in India. He's also the adjunct faculty member in Brown University's Department of Health Policy and an investigator at the Providence Veterans Administration. His broad research interests are in the formulation and application of credible research designs to examine questions of relevance to public policy. In recent work, he's interested in understanding the knock-on effects of COVID-19 on health systems. We have a fantastic panel today, and we're delighted now to introduce the panel moderator, Professor Mukund Padmanabhan, Visiting Professor of Practice, Humanities and Social Sciences at Krea University. Popularly always called as our ex-editor of Hindu between 2016 and 19, Mukund has a varied set of interests, including politics, legal affairs, and literature, and we couldn't have found a better fitting moderator for Dialogue Sans Borders. With that, take it away, Mukund, off to you, and I'll see everybody at the end for the Q&A, and please do keep those questions coming as you observe the panel's perspectives. Thank you, and welcome all.
Thank you. Thank you, Kala. So my first sort of question is a very general one, and I think if you look at a map of COVID-19, one that maps both incidence and death, one of the first things that strikes many people is that countries where the health system, healthcare system is much better, and arguably where the public health infrastructure is also much more robust, these countries seem to be more affected than some others. I mean, Western Europe and the Americas compare badly today with Eastern Europe, Southeast Asia, Africa, and even as things stand today, many parts of Asia. So, of course, this map is changing, and we know the curve is growing in Eastern Europe and so on, and it's flattening in the West. But my question is this, is there a coherent or rational way we can explain this mismatch between the quality of overall healthcare and the efficacy of public health systems and the trajectory of COVID-19? I mean, has it got to do with factors that are objective, such as swifter lockdowns being put in place, demographic factors such as lower life expectancy, life expectancy, or medical decisions, that got to do with testing, which of course, plays a role when it comes to calculating incidence? Or are we at a position now that we still don't have enough data to explain and understand this trajectory of COVID-19? Dr. Jha, can I request you to take this question first?
So thanks first of all to Krea University and to Kala and other colleagues for inviting me to participate on this webinar. It sounds very, very interesting and great to meet so many wonderful colleagues. So Mukund, to your question, it's really a very complicated question with an even more complicated answer, I would say. So the first thing to say is that some would take issues with your assertion of US having a very well-developed healthcare system, but in general, I think it's complicated in terms of biology. I think the seeding effect is something we shouldn't forget about. So the virus got seeded really early in many of these countries, and so both the number of cases and the adverse effect of these numbers was very, very prominent in these countries. I think the population demographics and the difference in the population demographics of different countries have been well described. So the higher age of these, the average age of populations in some of these countries. And the third thing to say is that despite everything else, I think the transparency in reporting in these cases have been much better than some of the other countries that, for example, you and I live in, for example, in India, right? I mean, both testing and the desire to share data with people in a very open and transparent manner without being afraid of what it tells about the leadership and the healthcare system, etc. So, I mean, less requirement of controlling the narrative, which has not always been the case, I must say. I think politicians will have an instinct to control the narrative wherever they are, but it has been much worse in some countries compared to some others. I will leave it at that. I think my understanding is that in terms of biology, the virus is not different in different parts of the world, but it is the various things like the seeding effect, the population distribution, and the way the healthcare system has responded, which makes the difference. Eventually, I think it will be pretty safe to make a prediction that the countries or the parts of those countries which have the worst healthcare system will eventually fare in the end much worse than those that have better healthcare systems.
So we have an answer which suggests that there are some objective factors at play in sort of determining the growth and the incidence of the virus, deaths, and so on. My question is, as it stands now, I mean, do you think Western Europe and the USA were somewhat complacent about zoonotic viruses, and previous ones such as Ebola, Zika were mainly tropical. SARS was arguably by and large an Asian thing. So could this be one factor, whereas countries like Japan and South Korea and Vietnam took firmer steps to lock down, and was the West a little behind on this, do you think?
Hello, everybody. It's a great honor to speak to everybody today, and I've visited India last year and had a great time. So thank you very much for the honor of speaking today. So this has been a global tragedy, and for the UK, it's been a national tragedy. I think the UK is one of the worst countries in the world for the death toll right now. And it's been very, very upsetting for British people and a very big dent in national pride. And I could probably write an essay on why the reasons are. I think a lot of the key points Professor Jha has already addressed. I think I would divide them into why countries are vulnerable and then the government response. So on the vulnerable side, As Professor Jar said, the seeding is important. Countries like the UK and the USA have a very, very large number of international arrivals. The population structure, a lot of elderly people. I have to say in the UK and in the USA, we have a lot of obesity, particularly compared to the rest of Europe. UK is a particularly obese country. Climate may have a small role. The virus may do a little less well in humid climates, for example. What time will tell. There are some reporting biases as well. The UK does have a reputation for being good on reporting data, and is reporting deaths as what we call any mention, whereby if there's a possibility that COVID-19 is involved, it goes down on the death certificate, even if the person was terminally ill with cancer, for example. But putting that aside, you have to look at differences in the cultural response and in the government response. So starting with the culture, I'm very, very much in agreement and interested in Chair Makund's point about some Asian countries like Japan being very wary of viruses after the experiences of the first SARS and avian flu. There's a culture of wearing masks, a very hygienic culture, stay home if you've got the common cold. In the UK, we're very keep calm and carry on. So people go to work with colds. I used to live in Thailand, and I would go into the office with a head cold, and I soon learned that that wasn't the done thing in Thailand, and you have to keep your germs at home, which we're only now realizing is a good thing in the UK. The UK was very slow for testing. So the country we compare ourselves with is Germany. Germany is probably about the best in Europe at handling COVID. It's a very equally international country, a lot of arrivals and so forth. But Germany really got off the blocks on testing very, very early, social distancing measures and lockdown. And I think and the wearing of masks. I think the last thing to say is there are a lot of cultural things about how much people obey rules as well. And there may be some countries are quicker to listen to their governments and trust the governments, and our government has not performed well.
John and Kalyan, you have some data on this, the sort of, and some interpretation of the COVID map. Would you like to share some thoughts with us on this, and also expand on anything that Dr. Jha and Susie have said?
Could you put up the map?
Yes.
Yeah, there we are. Right. So I'm going to make a couple of comments. The first goes to what Dr. Jha had to say, and that was about how something is viewed. And if we go back to the Spanish flu, the fact that it's called the Spanish flu is because Spain was a neutral country and was actually declaring its numbers, while other countries that were belligerents in the First World War didn't do that because it might affect morale. And that's an important, and it's ironic because if there's even the slightest suggestion that COVID-19 is called the Chinese virus, for example, it would be quite a different matter politically at this point in time, however that is particularly viewed. It's interesting that we're looking at the United States and Western Europe as being some standards of reference so far as health is concerned. It might be worthwhile looking at Western Europe, not so much as a monolith, but as different constituent elements. For example, we see a lot of the cases happening in Southern Europe. If you were to look at Italy, Spain, I mean, Southern France, then on to Greece. Sure, it goes up to the UK, but I'd like us to take a look at that. And I'd like to thank members of our team over here, Kausa Mehta, Ananya Raju, who have to put these graphs together, as well as Akshay Jain, along with Kalyan, to look at this. And one of the reports that they shared with us suggested that different cultural practices were coming to the fore. In Italy, for example, the fact that you had families living together may have been contributory to elderly members of those families actually getting the infections the sooner, something that wasn't seen for a while in places that had more nuclear constitutions to families. That doesn't necessarily explain what's happening in the United States right now, which is off the charts. Kalyan, would you like to show these? Go ahead.
Okay, so this is the graph about the current health expenditure as percentage of GDP, and this is our team has shown in the graph the percentage of GDP of United States, Australia. So United States is the highest curve here in blue. I think the others will be difficult to judge, but in general, it's Australia, New Zealand, Sweden, Russia, Brazil, India, UK, and then we go all the way to Iran. So some of the low spending countries are at the bottom, bunched at the bottom. So that is something that we were looking at, that what is the geographical spread and if it can be explained in terms of the health expenditure in percentage of GDP. Another interesting thing that we were looking at is the COVID testing policy. And I thought that that will be a small point to this, that so this is a global map of, for example, in red are the countries where there is no testing policy, and in green where there are countries which are testing even the asymptomatic population. Now, so basically that shows a very interesting spread. But one thing to note is that, for example, in India, it shows up as an open public testing, including asymptomatic population. But then we were doing some search that shows that it has to have a referral. So basically, one has to go to a doctor saying that I might have been exposed to COVID if I'm asymptomatic, and the doctor will refer, only then I can get tested. So also the colors, when it's kind of all lumped together that it's open for public testing, there are, I think, granularity as to what it means by open for public testing. If I just want to get tested today, I cannot do it. I have to go via a doctor. So these are just some of the things that we wanted to look at. And I think, John, you want to add anything to this?
No, I think this is a good sum up of the situation. There's been some question of clarity about this particular slide regarding India, because there have been reports saying that you need to show some level of symptom to get tested, and that's largely because of the disparity between the possibilities of testing and the size of the demographic that we are speaking about. But hopefully there will be the possibility of more testing, even if there are situations of the asymptomatic, as is suggested on this slide. One other point one would like to make, and this was something that, again, Professor Jha drew reference to, and that was about what was happening in places in East and Southeast Asia. And Susie also mentioned this, and that was about how experience sort of helps with allaying apprehension, or at least knowing how to deal with things. And again, reports from Hong Kong suggest that it's not a complete lockdown, but it's a controlled lockdown. So they're drawing upon that. You do have access to services, you can go out, social distancing is being maintained, and that's sort of a certain level of acculturation that's emergent from those experiences. Yeah. Thank you.
Shailendra, so you've heard all of them. Do you want to take off on anything that anyone has said and respond to that?
Yeah, hopefully the connection's clear. But I mean, just one point to sort of first, just leading off from what you started off, I think, again, this is about the United States. I mean, it's obviously, I mean, the point about the good healthcare system. And I think that the response was, well, it's not very clear that it is a great healthcare system. I just want to point out that I think there's enough inequity within that healthcare system. It works for some, it does not work for quite a bit of the population. and especially the minorities and the poor have actually would not probably feel that the health system has worked for them. And if you look at, I mean, again, some of the data, I think the second point you were saying, do we need to wait for more data? We probably do, but I think given the current evidence, it's sort of apparent that there's a disproportionate share of the minorities and the poor that are being affected by this pandemic, right? I mean, so I don't know that the healthcare system actually probably has not worked for them in the past, and it's clearly sort of showing up here in some of this. So again, I just wanted to make sure that we understand there's a fair bit of heterogeneity within the United States in how this is actually playing out. So I'm going to just stop there.
Absolutely. There's no doubt about that. I mean, I was just taking the map and looking at it. There are richer countries, there are poorer countries, and, there could be various reasons why the West got off the block first on this. And as Dr. Jha said, it may be just a matter of time before this affects the poorer countries and in much more virulent and problematic fashion. Just taking off from that, I mean, Sweden's become the kind of poster boy for the herd immunity strategy, which of course is sort of predicated on this belief that, yeah, the virus is going to be around, for a while, at least a few years. And lockdowns by their very nature have to be short-term and temporary. So they don't really help very much. And I just want to start asking a couple of you, whether you think this is a sustainable model, this kind of strategy in your views. And if you take the numbers now, I know we talked about Southern and Northern Europe, but you find that Sweden is doing better than, and Sweden's not doing well at all, but it's also probably doing slightly better than Belgium, which is, got the highest rates going. That's also in the north. It's not doing too badly compared to UK and Spain, but of course it's doing much, much worse than its Scandinavian neighbors. But the thing about this is, I was just reading something that the Swedish state epidemiologist said a couple of days ago, and he expressed surprise that the immunity levels in Sweden were still very, very low. In fact, there's studies to show it's higher in some parts of Italy than it is in Sweden. So, Susie, if I can just ask you, I mean, do you have a view on Sweden's policy generally? Is herd immunity even an achievable goal, a desirable goal, or has Sweden got it all wrong?
Thank you very much. It's a really interesting question. And given the large number of countries in the world, I think it's a good thing that one country is trying this. And ideally, we would do a giant randomized controlled trial and get different countries to try different things. So Britain actually started off promoting the idea of herd immunity, and it caused a lot of anger, partly because the general public didn't like the term herd immunity and said, now you're treating us like animals. But I think you have to ask yourself, how are we going to get out of this? And the alternative, which is lock down and sit tight till there's a vaccine, is actually quite problematic. A vaccine, we can talk more about vaccines later, but it may actually be quite difficult to get an effective vaccine and then to get it out to all the right people. So herd immunity is usually how we cope with common cold viruses and to some extent flu. And it's very interesting that the proportion of the population coming back as having antibodies is low. I'm involved in research on this and I could talk at length, but just to briefly summarize, first of all, the biology of running these assays is very difficult and the assays vary around the world. So comparing different countries, they're probably using different assays, and that could contribute to differences when you're comparing different countries. And secondly, we're increasingly feeling that it's not just about the antibodies you measure in the blood. This isn't actually a blood-borne virus, it's a respiratory virus. And we know from studying seasonal coronaviruses that cause the common cold, and to some extent from studying SARS, that there's important mucosal immunity, which is the immune response you get up your nose, and you get antibodies called IgA. Those of you who've studied biology will recall, which live in your mucosa and may be very, very important. So there's research ongoing to look at that. We also know that the T cells in your blood, so a group of white blood cells in your blood, are another important form of immunity, and my lab's doing some research on that. And then there's also people who are probably fundamentally resistant to the virus. So if it gets up their nose, it somehow doesn't take a hold, and that might be because of their genetic makeup. They've got certain pattern recognition receptors that fight the virus and don't let it in, or it might be their microbiome, the bugs that harmlessly live up their nose. So there's all sorts of reasons why that simple antibody measure coming out of Sweden saying 5 or 10% immune doesn't represent the whole picture. And then and the final thing I'll say is that the flaw in this comparing countries' methods and looking at Sweden as an experiment of herd immunity is the big differences between countries. And I think one thing I didn't really emphasize earlier was the effect of population density. And I think this is quite relevant to India. But if you look at Belgium, it's the most densely populated country in Europe, and Sweden is less densely populated than the UK, which is also pretty densely populated.
True. I mean, that's Belgium's explanation for why, things are so much higher there than elsewhere as well. But so Dr. Jha, is testing, isolation, and contact tracing, do they still remain the best methods to prevent clusters from breaking out into big waves? Have the Swedish got it all wrong? Do you agree with Susie? Shailendra?
So just a quick point here. I mean, I think, and I was looking at some data earlier that, although it seems sort of, I mean, I think Sweden, I think the issue is they sort of try the herd immunity model. It doesn't seem to have worked. I mean, in terms of like, there's fairly high, I guess, relative death rates in Sweden. But if you actually compare the non-COVID deaths, right? So, I mean, basically when you lock down countries, there's less access to services for sort of non-COVID healthcare reasons, right? I mean, for going in for regular checkups, cancer treatments, sort of heart disease conditions. And so if you look at the data from Sweden and compare across countries, it's the one country that relative to COVID deaths, non-COVID deaths are actually minimal, right? I mean, so I think if you're looking at overall, right, COVID and non-COVID, I think, I mean, it's not clear that this has actually been a failed experiment in Sweden, right? Because obviously when you lock down, you're sort of, essentially, while you might be saving a little bit in terms of lower COVID-related deaths, right? It's not clear that the same would happen for non-COVID deaths. But again, I mean, that was sort of broad data that I looked at across countries, and this one fact sort of really stood out. But I mean, I'm curious to look at that a little bit more to see if that in fact is true.
Dr. Jha, we kind of lost you as your screen got frozen. So can you just, take off from where you left us? Yeah.
No, sorry about that. I was just making the point that basic principles of epidemiology always remain relevant, and we need to go back to them. And I think there are a few things now we know work. For example, physical distancing works. Wearing masks is helpful, in preventing the spread and protecting people. So we should be doing that. I think the explanation that Susie provided about the different facets of immunity and why is it not just a simple reductive explanation that we'll all become immune, because we don't even know whether even if actually the antibodies make you immune, what is the level of that antibody in your blood? We don't even know that. So I think there is a lot that we need to learn there. But in the meantime, we have to go on, and life has to go on, and we have to basically follow the principles that we know have worked for a few centuries, and we should continue to follow those principles. And at this stage, I think testing, contact tracing, they remain extremely relevant, and most of the countries that have managed to contain the spread or mitigate the disease have followed those principles.
Thank you very much. Kalyan, I think you wanted to respond to something Susie had said, or at least ask her a question. So can you just do that? Yeah.
Sure. Thanks, Mukund. So this is, I think, the question to mainly Susie and also Vivekanand, if you can elaborate on this. This is a very naive observation that we were looking at the more recent outbreaks. And one thing that we noticed is that they have mainly been of viral in nature. I mean, starting from AIDS of 1980s, SARS, MERS, Nipah, Zika, Ebola. So, and now COVID, of course. Another interesting trend that emerges, I don't know if that is necessarily true, but many of them are RNA viruses. So basically, I suppose along with that, it comes the property that they can mutate very rapidly, the RNA viruses, just because of the nature of the virus. So I was wondering that if that is really a trend, or what you think about it, any perspective.
Susie, over to you.
Yeah, I can have a go. It's a really fantastic question. So why is it that these outbreak pathogens seem to be viruses, and in particular RNA viruses? So first of all, I could go out into Oxford and find about 10 evolutionary virologists who could answer this question so much better than me. But I will give my thoughts. And first of all, there's quite a philosophical question about what makes a good pathogen. And to be a good pathogen, it depends what you want. You can be famous like Ebola, which means you're very, very dramatic and you kill a lot of people. But actually, Ebola outbreaks tend to die down again. And that's believed to be partly because they kill their hosts a lot, which actually isn't very good for a pathogen. And they're mainly, they're highly symptomatic. So you're able to isolate cases as well. And then another way of being a good pathogen is just to persist. So you can be something like a lowly tapeworm that infects a lot of the population. I think one of the world's best pathogens is probably TB, because it infects a lot of people, possibly a third of the world are latently infected. And I think the reason RNA viruses cause these problems is partly in the biology. Some of them are quite cunning and seem to be good at not bringing out the best immune response to prevent them. So if you take the coronaviruses as a group, unlike some viruses, with measles, for example, if you catch measles, you're ill, you get better, and you have really, really high IgG antibodies that last a lifetime, and you don't catch it again. Whilst with seasonal coronaviruses and SARS-CoV-2, what we see is not everybody gets antibodies. The antibodies maybe don't last very long. They may be not that good at neutralizing the virus. So I think it's something to do with the biology of the virus. Can anyone else have useful insights here?
Dr. Jha?
Sure. So I think Susie has provided most of the facts around viruses. I think we have to realize that we live in a world where present is really so all-consuming, and right now it's the time of coronavirus. So we think there is nothing worse in the world than coronavirus. But if you, when all is said and done, I think antimicrobial resistance will still kill more people than coronavirus will. TB will kill more people than coronavirus will. And even common cold will kill a large number of people, maybe not as many as coronavirus. But we live in a world where attention span is somewhat fleeting. So this is not to minimize the impact of COVID on our societies. In fact, it has had such a disruptive impact that the influence will go beyond just the number of deaths that it has caused. But in terms of the pathogens, if we just go to pathogens alone, there are pathogens who have really learned how to live themselves and how to kill their hosts in a way that doesn't kill themselves, right? I mean, they can live forever and they can continue to have a humanity for a long time.
John, Susie mentioned Ebola, which she described as sort of dramatic, flamboyant, but not a very cunning virus, sort of, ran out of luck because of that. And you referred to the Spanish flu, and which, of course, infected a third of the population of the world, 500 million cases. Estimates of deaths vary. Some people put it at 50 million. But in many ways, in 1918, we responded the same way as we're doing now. Social distancing was practiced, masks were used, there were lockdowns, there were, in fact, different kinds of lockdowns in different cities, even within America. And there's debate about, whether one city was, more badly affected because they were less strict, and some other did better simply because they were stricter and so on. And we also know, and one thing about the Spanish flu is that the second wave, what they call the second wave, killed considerably number of more people than the first. And I know that there's literature to suggest that, talk of a second wave is non-scientific, and it's a very lay way of putting this. But given the similarities between, the way we have responded to that one and this, just in terms of social distancing, masks, and so on, despite so many years have gone by, over 100 years, do you think there's a case for believing that, there will be, we need to be constantly on guard as a second wave simply because of the other similarities?
Thank you, Mukund. A few points. What's different between 1918 and now is the fact that they didn't even know it was a virus at that particular point in time. The nature of this would be elucidated only by Richard Sharp in 1934. They were talking about the bacteriology of influenza at that particular point in time. The fact of a wave was also largely historical. The first wave, if you call it that, was happening towards the end of the First World War. And then something happened between that moment and the next, and that was the troops returned home, right? So you had, even in India, you had Indian troops coming back, entering the port city of Bombay from Mesopotamia, even then they were coming back from Western Europe and theaters there. And that's just one example when things started to happen. I'm not entirely certain that we've got quite so dramatic an event historically that's going to occur between these. You've had lockdowns and then you've had lifts, but unless there's something cataclysmic that occurs that we simply cannot foretell at this point in time, I don't see that occurring. You're right about the United States. The two of the major cities in question were St. Louis in Missouri and also Philadelphia, where St. Louis had a lockdown of a kind, and they maintained this. And so the curve the situation lasted longer, but the curve was fairly flat through. There was a bit of a spike, and then there was a sort of clampdown again. Philadelphia had this massive parade, and then all hell broke loose. And so there are those particular examples. And so there's a great deal to be learned from those particular situations. We've been discussing in our group, the members that I mentioned earlier, and that is this question: what is a wave? How do we know that a wave has ended? And if we don't have something historical that actually comes into to have a fore and after of that particular situation, I think it would be harder to tell, particularly because you're seeing different trends in different countries. China, then Italy, then the United States, South Korea in between. And you see this right now. Then we had Brazil take off. Numbers are changing. Now we're hearing about South Africa. We're hearing about what's happening in Lagos in Nigeria. These are all frame shifted in terms of time. So that will complicate that question tremendously. Yeah. Thank you.
Yeah, great. So to anyone, we're looking at fresh cases emerging in South Korea, Beijing again, in small ways. Sure. But are these signs that, and one of you, I think it was Susie, you mentioned that there could be a link between the, incidents and heat and humidity and so on. So could we be, is this something, do we have enough material, enough data to get a sense, at least, that this is going to be with us for a while, few years? Anyone wants to take that? Shailendra or anyone else? No one? Okay, Susie, you want to take that? Is this going to be with us for a while?
Dr. Jha was just picking to respond. I think Dr. Jha was just taking up to respond as.
Okay.
I think Susie is best placed, so maybe Susie, and then maybe I'll say something.
Okay.
So this is the question that everybody's asking. I think if I was forced to predict, I would say it is going to be with us for a while and become a bit more like seasonal flu, perhaps. I don't actually have a good understanding of your seasonality of influenza in India. Perhaps one of you can educate me, but certainly in the UK, we have a very rigid seasonal picture. So I might well be wrong, and I've been wrong many times this year about this virus. But I would predict in the UK anyway that it will kind of stutter on a little bit over the summer, and then come maybe November, December, it will have an outbreak again. But the size of that, I don't know. And I think it's only really in the Northern Hemisphere, it will only really be by about March 2021, we'll really understand what we're dealing with, by which time we should have information about vaccines as well. And it could be 2 or 3 years before things settle down. But I might be wrong.
Dr. Jha?
Yeah, no, just to add to that, I think, at this time, it does look like it will stay with us for a while. A major difference between the Spanish flu of last century and this one is that I can safely say, and I won't be wrong there, is that we'll get a vaccine faster than the one last time. But you see, one of the things that is relevant here for this discussion is that lockdowns, of course, if we had an indefinite lockdown, will probably be able to completely kill the curve. But we have the lockdowns are easy to impose but difficult to come out of, which is what we are facing right now. And it's coming out of lockdown, which is going to give rise to whether you have a second wave or a stutter or whatever, which is what many US countries are facing, and which is what we are seeing in India. The lifting of the lockdown has led to this increase in the number of cases. So I think this behavior does tell us that this will stay with us unless we take very strict public health measures, and they remain basic public health measures. Even if we have a vaccine, in a country like India, to take the vaccine to the last person is going to take us 10 years or more. So I think for us to be able to see what we need to do about it, we need to come back to the basic principles of public health.
Shailendra, I just want to turn to you. Will COVID-19 become the catalyst that persuades countries to invest more in public health? I mean, and if so, what do you see as the principal steps to improve the readiness and capacity of health systems in dealing with a phenomenon like this? I also want you to sort of dwell on a point or the central point, I thought, in a column made by Srinath Reddy in the Hindu some time back, which began by saying when the public health sneezes, the economy catches a cold. And the thrust of the article was to suggest that, look, investment in public health is not some sort of dead write-off. It is also good economics. And I just wonder if you can address these two issues. One is it going to change the way we look at public health? And two, is public health, investment in public health, good economics as well?
So, it's a great question, and you refer to an article written by certainly a top scholar in the field, Srinath Reddy. But my sense is that this is just more by past experience, right, of countries that economic crises has definitely triggered a response in some countries to investing more in public health, right? So the Asian crises, the economic crisis of the 1990s led to, certainly a revamped healthcare system in Asia right after World War II. England made pretty massive strides in investing in public health. A little bit that was the same was true with Japan. So I think if you're looking at past experience, there's certainly sort of some evidence that countries could do that, start investing more heavily in public health. so the question, of course, has always been as to how you would actually come up with that investment, right? I mean, how do you actually raise the money for that? And I think that is a much more difficult question. And I think that is a question to which I'm not sure I mean, so if you're asking how would India respond, right? I think the intent would be to respond very strongly. But I mean, in terms of how they would raise the money, and it's going to be quite substantial sums of money required to do that, especially, you know, if you think about what kind of investments might be required. One is with healthcare workers, right? So one thing that's clearly happened here is it's shown that this healthcare system that we've had has been really stretched very thin. You know, we've had healthcare workers who are previously going door to door to households to figure out from mothers about child immunization of a baby, who are now being tasked with sort of doing COVID duty, which has now just thrown up a whole different problem of, you know, gaping hole in the immunization rate. So, I mean, basically, I think the issue is, and this was a sort of to quote a phrase from Siddharth Mukherjee, who is a Pulitzer Prize winner, classmate of mine. He said the healthcare system is overtaught to be overtaught, and, you know, TAUT. That, you know, really what's happening is it's a very, I mean, system with no excess capacity. And so if one thing that could happen potentially is a greater investment in healthcare workers, I think that would be a tremendous response, because you don't want this sort of trade-off between sort of, you know, spending healthcare resources on one kind of disease just to leave open a gaping hole in something else as basic as immunization, in which we've actually made reasonable strides over the past decade or so, right? So that's one thing. That, I mean, I guess what I'm saying is, I think you would expect, I mean, that would be probably an appropriate response. So your second question was in terms of the, you know, is there an economic reason to invest in public health? And, you know, I think, I mean, the answer to that would be obviously a yes, because, you know, so far, I think, I mean, this entire issue with this lockdown, you know, and part of that is, I think if you had, you know, I mean, basically just think about India, the amount of time it's taken for us to open up. I mean, it's still staggered right now. Chennai is still under lockdown. I think with very intense testing, right? I mean, and very sort of, I guess, specific testing, right? I mean, it's just not a question of public health. I mean, basically, I mean, not only just investing in testing, but also trying to figure out who you would test. So you want a data system, you know, overlaid on top of this to sort of figure out who the folks you'd want to isolate for testing. But I think I mean, and trying to do that quickly enough. I mean, I'm imagining that, you know, this sort of prolonged period of lockdown, which has actually probably created, you know, this massive sort of, I guess, downturn in the economy. I mean, maybe some of that could be sort of probably at least not prevented entirely, but probably sort of managed a little bit better, where with a much more effective testing system, which I know others have alluded to as well, wherein, you know, you sort of get a handle on this very quickly. But so I mean, again, I mean, I think there is a strong economic reason to invest in public health, but I think it still begs the question as to how that's going to happen. I mean, right? I mean, the Finance Commission of India right now has, you know, put up a couple of alternatives in terms of how one can raise the funds for more investments in public health. I think only time will tell, but yeah, I guess I just want to stop there to sort of say I think it's an important reason to invest in public health, and yeah, I mean, I think it's a question of whether we have the will actually to actually do that.
Yeah, John, you want to make a quick response from you?
Yeah, it's interesting. I was thanks, Mukund. I don't know whether many of you listening have followed the Netflix series on the coronavirus. There are 3 episodes, and I draw attention to these because they do 3 very different things. They've appeared at different points in time. The first is somewhat, it's called The Pandemic, and ends with this fairly bullish statement about the virus shouldn't be messing with humankind, and we're so prepared now at an unprecedented level. And then it moves to the vaccine itself. And the third is much more about coping mechanisms and how much, and you can see how differently there has been changes attitudinally in that episode itself. But even in that first episode about the pandemic, it's interesting, you've got the Gates Foundation, essentially part of what is called CEPI, and which is the Center for Epidemics Preparedness and Innovations. And one of the things that he was saying and pointing out is that there isn't much money if an epidemic or pandemic ends. And part of the problem over there is you can start with preparedness. There was a case in Baylor where there was a team that was working on SARS-1, and then funding ran out for it. And so they said, had they been able to continue with that, then they might have been in a place where they could have dealt with phase 1 of a testing program that now does not exist for them because they didn't have the money for it. And so in some senses, that is a very real issue so far as public health is concerned. If you don't have the money and you have those that can afford to support it not doing so, we might continue to end up in situations like this.
Yes, Kalyan, you have a point or a question to ask of Dr. Jha, I think, right?
Yeah.
Right. Okay. Thanks, Mukund. Yeah, this is again slightly technical in nature, but one cannot wonder when looking at the recent developments, and especially COVID, that the drug molecules or potential drug molecules, candidates that we are pinning our hopes on. And so initially it was the hydroxychloroquine, which is an anti-malarial drug originally. Second, the most promising candidate probably, and I would like to hear your opinion, is the remdesivir, which is the, I think it was originally in the Ebola project, and it was aborted at some point, and then it has been taken up, if I understood correctly, about the trajectory of remdesivir, and now it has shown some promising results in COVID tests. And recently, I think also dexamethasone, it's like a corticosteroid molecule that has been shown some promising result. So I just wanted to have your perspective on this, like how these molecules are shortlisted for testing. Was the strategy to go about the molecules or for new molecules for that matter?
Thanks. So that's a great question. So, you know, whenever you have a new disease that is causing such a big public health problem like COVID-19, we don't have time to discover new molecules right away. So the first thing that people do is to try to see if one of the existing molecules can be repurposed to work against any given condition. In this case, it is COVID-19. Some of the data that is used is basically preclinical data. Some is based on simply assumptions which are made because we know something about the viral structure. We know something about, you know, in vitro data on cell culture systems and so on. And based on that, people take a shot, you know, and because timelines are so compressed, these molecules need to be tested in clinical trials. And this is where I think the group that has got really a bloody nose in this is the group of clinical trialists, because you know, because of the way clinical trials have been conducted or their results interpreted in the end. So there has been so many mixed messages, and even a number of so-called organizations that are supposed to make policy have tried to jump the gun, which includes you know, Indian Council on Medical Research, but Indian Council on Medical Research is not alone. I think these kind of organizations throughout the world have come up with recommendations that have kind of tried to go ahead of the science. So hydroxychloroquine, no one even knows, and right now we are really short of good quality clinical trials in all of these. So the one that the most recent one, please remember that we are talking only on the basis of press release that has come from the group. We haven't seen detailed results of this particular study, and you know, the data seems to be much better than what we have at least heard from others.
So Dr. Jha, are you talking about dexamethasone now, or sorry? Yes,
dexamethasone. That's the latest one, right? I mean, so that's the one that we have. So dexamethasone, it's a steroid molecule. So it is not something which it's not an antiviral agent. So it simply works on reducing the severity of the inflammatory manifestations, possibly that occur secondary to the coronavirus. In fact, if anything, if steroid does its job, it might even increase the load of the virus in the body. So so these are the kind of things that that is something we need to be remembered. We need to remember that eventually, if we have to find a way to kill or deal with this disease, we will need to use a combination of drugs that act at different levels of the pathogenesis, as we call it, of the disease. So there could be maybe some antiviral agent, there could be some agents which act on the mediator pathways, and then there could be some agents which really reduce the clinical manifestations. So I think it could be at least a combination of 2 or 3 drugs that eventually might work. But most of this data that we have right now is messy, and we need to be really careful in making any kind of conclusions. We think even though there is a seemingly reasonable quality data supporting dexamethasone, it is an open label study in which clinicians are able to choose which patients they want to treat with dexamethasone and which they don't want to treat with dexamethasone. So the generalizability of this result to the wider COVID population is still in question. And there is a general principle of clinical trials is that even if you have shown something to be effective in one clinical trial, you need to really confirm it in more than one clinical trial. So we have some ways to go before we know which drug will work and which will not.
Okay, maybe one last question before we turn it over to the audience. Susie, this is for you, and this is the big one. You're based in Oxford. Where do we stand, vis-a-vis the vaccine? We keep reading about, tests on monkeys, and we keep reading about whether, declining cases is going to have an impact on its efficacy and so on and so forth. So can you give us a sort of update on what's happening on that front?
Yes, I can. So I did my PhD in the Jenner, who has designed the COVID vaccine in Oxford. Yeah. I did my PhD on malaria vaccines, actually. And I'm working on other vaccines now. I'm not working directly on the vaccine trial, but I'm working on immunology and alongside the scientists there. And I'm also in the vaccine trial. So I've had either the COVID vaccine or a meningitis vaccine, I don't know which. And my husband's is in the vaccine trial as well. So I'm pretty surrounded by it. And we all want it to work. So we all want it to work, but will it work? And that's the question. I also have to be loyal to my institute as well here. So I think if I had to guess, I think it will partially work. So I think probably find that the vaccine induces antibodies. There'll be a debate about, are they as high as we'd like them to be? Are they as neutralizing? Not just are they there, but do they work as well as we'd like them to be? And if not, that may be because of the biology of the virus rather than the vaccine. And I'd imagine if this particular vaccine platform, which is based around getting a harmless viral vector, which is an adenovirus that usually causes a cold in chimpanzees. So it's that particular platform is good at getting antibodies and T-cell responses. So if this one doesn't work, I'd imagine that other candidates are in trouble as well, but we'll see. I think what we'll probably have is some antibodies, are they enough? And then when we have a chance to assess the efficacy, perhaps it will work in some people and not in everyone. Perhaps it won't. What we'd love is a vaccine that induces full sterile immunity. That's always the holy grail, which means if you've had the vaccine and you encounter the bug, you don't get it at all. So you don't carry it, you don't get sick, you don't pass it on. Sterile immunity, and that's ideal, and that means you contribute to herd immunity, and that's very, very good at knocking the pathogen on the head and it can't get a grip in your society. However, in this case, if the vaccine actually gave some protection, for example, you still got the virus, you're still infectious, but you didn't get the severe complications. So you didn't get pneumonia, for example, nobody had to go to hospital, and perhaps it converted SARS-CoV-2 into being more like the common cold. We'd be pretty happy with that, wouldn't we? So I would predict that when we do get results and we get efficacy results, we might be looking at a partially effective vaccine that works in some people, not in others. And then there'll be the question, how does it work in the more vulnerable? So it's currently tested in healthy people. How does it work in elderly people, people with diabetes and other problems? We'll have to work all that out. How long does it last? And then you've got the problem of manufacturing it for the world. And I know that AstraZeneca, who've taken over the vaccine, are looking at manufacturing it all over the place, including in India, I understand, because India has some of the world's best manufacturing facilities for vaccines.
Right. So we have about 14 minutes to go, and maybe we can take the questions that are there. I would just request all of you just click the Q&A, and if there's a question you'd like to handle, please say that. But I just start by just referring. Sorry.
I said I've got that the questions out, so I can moderate that.
So can I just refer one of them to Shailendra, which is basically this question from Diksha saying, with every country handling the crisis in its own way, what are the implications for multilateral cooperation in the area of public health? And this is an interesting one because while the world seems to be, while countries seem to be distancing themselves from each other in many ways, and international relations is in quite a spin. One of the emerging trends seems to be some kind of collaboration on health. I mean, I'm just referring to this announcement that GlaxoSmithKline and Sanofi would work together to develop a vaccine and so on. So, I mean, there seems to be some kind of, in terms of trade and exports and imports of PPEs, much more collaboration on the health sector, unlike anything else. So, do you have any thoughts about that? Is this going to change the way we collaborate in the health sphere?
So I'm just going to mention one point. Again, it comes back to this point about the healthcare workforce, and especially in India, right? I mean, so we've been blessed with this very large population, and a population that can actually probably be skilled fairly quickly to essentially provide essential services. Not only in India but outside too. I mean, in terms of crisis. So I think one response potentially would be to actually, sort of skill a workforce, healthcare workforce here that would be able to actually respond to a situation where immediate there's excess demand for that kind of work, not only in the country, but I think where we can actually export a lot of that workforce outside, right? I mean, because I think it's not, I mean, countries are not, in terms of resources, geographically, human capital resources, they're all different across countries. India has the advantage of the human capital sort of advantage. And I think that could lend nicely to not only bolstering the capacity for us to actually increase our workforce, which would then translate into increased productivity, but then also to be able to actually work with other countries to actually probably, I guess, tide over crises like this. So, I mean, that's just one area that I thought could be potentially an important one. So.
Okay, Kala, you want to take it from here? There's one question from Costa, which Susie said she'll take, which is on COVID deaths. So maybe you can refer that to her.
Absolutely. I was actually going to get to the whole chart on vaccine, and I thought I'll just get Dr. Jha to respond to that one question on the vaccine before we get back to. So with that whole positive bit that Susie left out with, there might be a solution. So there's one question around, you hinted on, if there was a vaccine, it's going to take 10 years by the time it reaches. So, and hence, what kind of distribution system do you think it would make sense is the question. Does that mean then now if we did get a solution, would it go to the red zones first, to the green zones, and how will this distribution system work if we have to not wait for the 10 years?
Well, thanks. In just
10 years?
Sorry.
No, Dr. Jha had hinted about if there was a vaccine by the time we get everybody vaccinated, it was 10 years. The question took off from that, yeah.
Right, thanks. So in just an egalitarian system, we would prioritize the people who are at the greatest risk of complications from the disease. So we would identify people who are, for example, the elderly, just like we do for other vaccines, right? I mean, we identify people, the elderly, the obese, the people with comorbidities, and so on and so forth. People who are vulnerable for some other reason, for example, who may not be able to access healthcare in case they fall sick. like those who live in remote rural areas. We'll probably try to vaccinate them in but let me repeat, in a just and egalitarian society. But we don't live in a just and egalitarian society. So I think the point that was made in the question is, should it go to the rich? Most likely it will, and this is how it happens. Whenever a new technology or treatment becomes available, it increases the inequities in the society. That is something which is very important for us to remember, because the people who will have who have the means, they will be definitely prioritized by just because of natural self-selection. This is how it happens. For example, I know from my colleagues in UK that when testing became available, the first people who went and got tested were really the healthcare administrators rather than the people who were providing healthcare, who should have been the ones who would have got tested first. I can see Susie smile because she knows this to be the case. So unfortunately, that's how it will happen.
Yeah, Susie, that question from Kaustav, coming back to you about to what extent does our understanding of the pandemic hinge upon the definition of a COVID death, and how is it problematic if different nations define it differently?
Hello, yes, thank you. Before this pandemic, I was working on antimicrobial resistance, and defining cause of death is always very difficult because humans, they often, unless something falls on your head, you often die of old age of multiple causes at once, and it's about the relative contribution, and it's very relevant with COVID-19. And I looked after a lot of patients in the last couple of months, and a lot of them were very frail with a very limited life expectancy, and it was a very unfortunate way for them to pass away. But it did mean that some of the deaths are maybe people who we would have seen a death later on this year. And I think different countries are measuring it different ways, as I said earlier, depending on whether you feel it was entirely due to COVID or COVID was just detected up their nose. And I think the solution really is looking at excess deaths, and there's some very nice data. The UK Financial Times has done nice graphs on this, as have others, where you look at the expected deaths for that time of year for that country, and you look at the excess, and it gives a bit of an indication as to how the country's getting on in its reporting, but with the caveat that countries vary in their mortality reporting anyway, and it's very, very difficult in some huge populous countries to gather high quality data on that. I think time will tell, and what will be interesting will be, when it's all over, after 2 or 3 years, we'll really understand what happened when we look at mortality trends across the world.
I'm going to direct this to John. This couple of questions there, which is somewhere in your domain, and this is about. We've agreed, this comes from Sajna, that agreed there's been a paradigm shift in the development of public health, institutionally and socially. But having said that, can there be new outlooks on the notion of public health? Is it just about prevention or remedial measures? In retrospect, what would be the present moment's contribution to public health, sociologically, politically?
Thank you, Kala. Thank you, Srajana. I did draw attention to this a little earlier from the point of view of what could have been done remedially. I mean, I mentioned CEPI. And when you're saying, was there something, is it a kind of work that you can do? Is it, in some sense, a response to some particular diseases that have taken on epidemic elements? And what happens when that epidemic ends? Do you just merely lose interest? And while there's every reason for you to continue looking at it, I mean, one major aspect is how many of these diseases recently have been coronaviral diseases, right? If you look at SARS, MERS, and right now with COVID-2, which is another SARS breakout. Another angle to consider is the politics of the matter, right? And what's happening in different countries. It's interesting that if you look at strong people, in this case, I'd say strong men, if you will, the way they're being propped up around the world in relation to particular countries. Think about Putin, think about Trump, think about Bolsonaro, think about, and whether there are, and what responses have been in those particular countries and the rhetoric that's emergent from there. It's interesting that Modi's done something different, if you see him in this particular context, in that there's been the lockdown rather than what's happened in other places. And so I would argue in this particular case that much of this institutional and societal response is tied into a political angle as well. And that's something of which we cannot lose sight. If there could be precautionary and remedial measures that could be taken, that would be just the commonsensical way of dealing with it. Unfortunately, common sense doesn't always obtain.
I'm going to defer back a question to Shailendra before I get to Susie. And Shailendra, this is around looking at the spend in public health. So the question is, if we do see India improve spends on public health, do we see then a revamp of the primary healthcare systems? And I guess the leading question to that is, would healthcare startups then have a whole new game to play?
Sorry, can you just repeat the question?
It's if there is an improvement in healthcare spending, would that revamp the primary healthcare centers? Is that where that might go? And would healthcare startups then would have a whole new role to play?
So, so it's an interesting question in terms of the primary healthcare setup. What's interesting is just before this pandemic broke, and I am assuming the question is sort of specific to India, but even if not, I'm going to actually focus on India. That before the pandemic broke, we were actually going to a primary healthcare system very systematically that was actually geared towards infectious diseases. I mean, it's always been geared towards infectious diseases. And that's why the vaccines essentially became the I guess the poster child for a very strong campaign of the primary healthcare centers. I mean, with the ASHA workers, but we were moving to a system that essentially was more sort of trying to handle non-communicable diseases, right? I mean, I think that's at least what the overall, I guess, the message was coming out, that we're looking at sort of very proactive sort of screening for sort of potential non-communicable diseases like diabetes and hypertension. And I think the sense was that our primary healthcare system were not geared towards doing that, and so there was massive resources. In fact, so there's something called the Health and Wellness Centers, a very recent effort of the government, where the focus was essentially on revamping them to essentially go towards more screening for non-communicable diseases. So in terms of, I guess to me, I think right now we're in this dilemma, right? Because this pandemic has now shifted the focus back to infectious diseases. While we were going sort of full steam with NCDs, thinking the infectious diseases are behind us, it's clearly not. So I think it'll be interesting to sort of see how it plays out with these healthcare centers, these what they call health and wellness centers, because again, I mean, I think the question is, how do you divide up sort of some amount of resources between sort of potentially care for prevention of infectious diseases versus more screening for non-communicable disease? I mean, that's one question. In terms of whether or not there would be a more of a sort of a spurt in sort of these healthcare startups, it's possible, I mean, that there is a spurt, but I'm just going to actually just put out this one point, that in general, interest across the world with these sort of what they call health crises has been very dramatic. It's sort of waxed and waned with the crises. So essentially, once the crisis passes, things sort of shift back to normal, right? I mean, I think in general that's been true. I mean, if you look at funding for sort of even sort of research on coronavirus, right after during SARS, there was a high peak, and that sort of completely plateaued out and sort of essentially bottomed out since then. And so the question is whether this sort of sustained interest in public health would be maintained for the startups to actually see this as a viable opportunity. But again, I mean, that was probably what I had to say on that.
Yeah, there's of course a lot of questions around the public policy end of it, and I'm going to just come back to one more question on the medical bit, Susie, which is come in earlier. You talked about mucosal level, and how do you think it may be affected by geographies where flu is highly prevalent or less so, and how do you think this kind of immunity will last? Do you think this kind of immunity will last for a long time?
Great. So two separate good questions within that. How does geography impact on mucosal immunity and how long does it last? I'll take the second one first because it's I know a bit more about it. So mucosal immunity is thought to be shorter lived than immunity in the blood. And it's often quoted as being up to 3 years. And that's partly explains why you get so many damn colds in your life. The first question was about geographical difference. It will vary around the globe. It will vary depending on what seasonal coronaviruses people have been exposed to, what flus they have, and probably also the microbiome, the bugs that live naturally up your nose.
Interesting. Thank you. So there has been a question. I wasn't too sure if Dr. Jha wanted to take this, and this was about, I'm going to kind of close in a few minutes. The Ayurveda allopathy debate a bit about, you know, do you see that playing a role as we go ahead? Because that goes into more the human science, as it says. So is there some thoughts on that? This comes from a student as well. But Ayurveda deals with the fine understanding of the subtle human body, whereas allopathy treats it. So is there going to be something that the healthcare system is going to look at from your experience?
Well, thanks, Kala. I am not an expert on Ayurveda, so I really can't claim to make any definitive statement there. But I think, you know, as scientists, we can all agree that any treatment that works needs to be proved using the right scientific approaches, which is starting from preclinical studies to proving it in clinical trials, and then looking at safety and efficacy, etc. You know, whether the right formulation is available or not. So while belief is important, I think we need to stay rooted in science. This Ayurveda versus non-Ayurvedic medicine has become more political than scientific at this time. With the caveats that I have zero knowledge on Ayurveda, I still believe that whatever we do must be rooted in science.
Absolutely, fantastic. Thank you. I think we're kind of getting close to time and some part of the panel wants to leave. So this has been great because the idea was to go from the medical background to the social implication to the economy, finance of it. And we had a fantastic panel out. So Mukund, for some closing words from you, and we can formally come to closure. Thank you, everyone.
Oh gosh, well, what do I close except by saying thank you very much, and thank you for, you know, so many different perspectives and for drawing on your own individual experiences and making this, I think, very interesting, both for, you know, someone who's invested in this as a discipline and also for the layperson. I think we've, you know, covered all tracks here. And so thank you very much. Thanks for being there. It's been a great panel. Yeah.
Thanks to everyone who attended. We look forward to the next one on social behavior. We'll see everybody soon. Thank you so much.